Hello and welcome to today's webinar, which is addressing the intersection of brain injury, aging, and behavioral health, offered by the National Association of State Head Injury Administrators. Thank you so much for joining us. I'm Maria Crowley. I'm your moderator for today and NASHIA's Director for Professional Development. And wanted to let you know that closed captioning is available should you need it. You can enable it at the bottom of your viewing window. If you need any assistance for today's webinar, just send me a chat. Questions for the presenters, of course, you can put in your Q&A window, and we will do our best to get to those along the way, or at the end. We're going to try to save a little bit of time for those. If you are not familiar with our organization, we are a national nonprofit created to empower state government and our partners to enhance collaboration and strengthen capabilities to address the needs of individuals with brain injury and their support systems. This is a little bit of the things that we provide. As you can see, today we are obviously focused on training and professional development, but we also focus on these areas as well. We are also a member organization, so if you're not a member, please consider joining us, and there's some information here on how to do that. We will be offering certificates and social work CEs if you're interested, and all of our materials as usual will be available after the webinar and archived on our website. And certificates are free to members and at a reduced cost to members. If you need any information about that, you can certainly contact me and use the information here. All right, without further ado, I would love to introduce you to our two presenters today. You're in for a treat. You are going to hear from two folks that have a wealth of experience in this space. First is Nirmala Dar. Nirmala is with Oregon Health Authority within the Behavioral Health Division and the Older Adult Behavioral Health. She's lead strategist. Nirmala is a licensed clinical social worker. She's got over 40 years of experience in all aspects of behavioral health in the public sector. So well-rounded in this field. She's deeply committed to disability justice, especially for people with serious mental illness and for individuals with cross-sector complex care needs. She serves as the older adult behavioral health lead strategist for Oregon's Health Authority's Division of Behavioral Health. And in this role, she's the project director and has been in that role since its inception. And I find this interesting. She's also the Pass R Level 2 State Director. And for the Health Authority, she serves as the BOLD Grant Oregon Health Brain Initiative team. She's the Geriatric Behavioral Health ECHO Champion, for those of you that are familiar with what ECHO is, and was very instrumental in building and finding funding for the first of its kind Geriatric Behavioral Health ECHO for nursing facilities, and played a key role in funding and establishing the Center for Excellence for Behavioral Health and Aging in Portland State University at OHSU, which is called UCBEC, I think they pronounce it UCBECA, which we did a presentation for at State of the States last year with Walter Dawson and his team, which was just fabulous. Welcome to Nirmala. With a lot of equal credentials, I want to introduce you to Amanda Krischer, who is with the National Council on Aging, also someone with a master's in social work, a licensed social worker. If you're not familiar with the National Council on Aging, what a treasure trove of resources they bring to the table on aging. Amanda has 15 years of direct service and program management experience with the council. She's a seasoned professional in older adult care as well. She was the previous senior director for a live virtual training program for older adult care professionals and a clinical social worker for community health program and hospice organization. She worked on her master's in social work with the University of Maryland School of Social Work in Baltimore. And as a leader in older adult care, she's presented at numerous conferences and statewide meetings. She's quite passionate about supporting healthy aging and is, as you have, if you've never participated in the council's mental health symposium, they draw about 5,000 individuals to that training each and every year. It's pretty phenomenal. And Amanda's beginning some new initiatives at the council, so you'll want to check those out. Welcome, ladies. Welcome. We're so delighted that you're here. And I'm going to stop talking and I'm going to turn things over to the two of you. I think we're going to start with Nirmala, and I'm going to pull my slides down and allow her to share.
Maria, you were going to launch the poll questions before I start. So if you'd like to do that.
I will.
So I have I think 4 questions, which I would love all of you to take a moment to answer. They're just true and false. And you need to scroll to, get to all 4 of them. After which, Maria, we could see the results, and then I will launch my presentation. I don't want to spend too much time on this. We'll give it maybe a couple of minutes so that we don't cut into our time. So thank you all. Please take a moment to answer these questions.
Looks like they're working their way through those.
Okay.
I'll give them just about another minute. Looks like we're at about 80%.
Okay.
All right, you want to see what we have?
Yes, please. I will just, yes, wow. Okay, so let's see what the answers are. Falls are a leading cause of TBI in older adults. Well, great. It's true. So 93% said it's true. Fabulous. Second, older adults for the most part have a slower recovery rate from traumatic brain injury. Absolutely right. True. 96% said true, which is the right answer. Individuals who have had a TBI are not at risk for suicide. Correct answer again, false. 95% of people answered it correctly. And then last question, fear of falling is not a clinical syndrome. And false is the right answer. So 82% got it right. So Maria, you have a well-informed audience here. They know my training. Anyways, I think I may be able to add something. Thank you all. Thank you, Maria, for inviting me. I'm so pleased to be here. I'm going to put up my slideshow. Just tell me if you can see it, Maria.
Looks good.
And if you don't mind just telling me 5 minutes before my time, hey, Nirmala, zip it up and hurry. So, okay. Thank you very much again. My topic today is addressing the intersection of brain injury, aging, and behavioral health. And again, thank you for inviting me. I'm not going to go over you will be getting my part of my slide deck. So I've just written a little bit more about who I am, including that I've worked for over almost a quarter century in community mental health programs, which are our safety net clinics, where a lot of people with traumatic brain injury access services. And so that has really been at the heart of my professional experience. And that I love being a coach, a mentor, and a trainer, and a content developer. So thank you again for having me. My objectives are fairly simple. we're going to look at the epidemiology of TBI for older adults. And again, I want to make this as interesting as possible for you. So it's not like a huge data dump, but really relevant information for your practice or wherever you work. Then what is the definition of traumatic brain injury? What are some unique risk factors for older adults? And obviously, the main part is the co-occurring behavioral, emotional, and cognitive effects of traumatic brain injury for older adults. So that's what we're going to cover in, I think, in the next 30 minutes. I always say, numbers paint a picture. And this was the latest data that I could get. It is not just for older adults, but it's TBI kind of across the lifespan. Look at that. In 2021, 69,000 traumatic brain injury deaths in the United States. 190 Americans die from TBI injury every day. 190. That's kind of like a plane load of a plane load, of people dying. That would be one plane crash almost every day. 223,000 TBI-related hospitalizations. And this is for younger people. 15% of all US high school students self-reported one or more sports or recreational related concussion in the preceding 12 months. So reflect on that, but just the number, 69,000 deaths and 190 every day. Now, what about older adults in particular? The primary cause for traumatic brain injury in older adults is falls. And it results in, a huge number of emergency department visits and equally large numbers for hospitalization each year because of falls, which then lead to traumatic brain injury. It is the leading cause of traumatic brain injury in older adults. And, you're going to see a call for action later in terms of falls and falls prevention and TBI prevention. And, falls are, for older adults, they're just like every day. They slip, their foot gets caught on a little rug or electrical cord. They miss the end of the stairs. So it's not anything dramatic like a sports injury. Yes, though there are sports injuries too for older adults, but it's just everyday kind of falls with these kind of tragic consequences. And this slide here is just showing you the trend in hospitalizations for falls-related traumatic brain injury. And this data is over a 20-year period. And what do you see? The blue dots are men, and the little triangles in orange are women. And as you can see, from 2015 onwards, it's up for women, but it kind of has stabilized. But for men, it continues to go up. And so essentially, over the last 20 years, the trend has been an increase in fall-related traumatic brain injuries for older adults. And that trend for men continues to go up. And this is important data for all of you, epidemiological data. Hey, what particular interventions do we need to put in for men to prevent falls and TBIs, for older men? So people who most commonly, how do they get TBIs? I've already said falls. Firearm-related injury. That means, a gunshot like to the head. Motor vehicle accidents. Assaults of any kind, including, by the way, domestic violence. But falls lead to nearly half of the TBI-related hospitalizations in general, but more so for older adults. Did you know firearm-related suicides is the most common cause of traumatic brain injury in the United States? Firearm-related suicide. Think about that. And then we've already established that people age 75 and older had the highest number and rates of TBI-related hospitalization deaths. So they accounted for about 32% of hospital-related, TBI-related hospitals, and almost more than a quarter of the deaths were related to older adults with TBI. Men were nearly 2 times more likely to be hospitalized and 3 times more likely to die from traumatic brain injury. And so here are people who are at greater risk. As we've already talked about, older adults are at risk, but racial ethnic minorities, veterans and service members, people who experience homelessness, people who are in correctional and detention facilities, survivors of intimate partner violence or domestic violence, and people living in rural areas. So all of you, I see we have a really great group of people. Do you work with any of these at-risk populations? What should you be thinking throughout my presentation today? Whether you work in a homeless shelter or you are working in a correctional facility or in jail diversion, or actually also in domestic violence. These are the groups at risk. So why are older adults at risk in particular? And like, what are those risk factors and how do they impact them? So any older adults who is having problems with activities or impairment in activities of daily living, like mobility, going to the toilet, getting up and out of bed, those are activities of daily living. That's a risk factor. If you have impairment, if you have depression, if you're frail, if you have a prior history of traumatic brain injury, whether it was when you were younger or you've had a prior fall, if you have any kind of socioeconomic disadvantage, whether it is income or transportation or any of those social determinants of health, if you're homebound, which essentially means you could be frail, you may have impairments of other kinds, so homebound, and you have pre-existing dementia of any kind, whether it's Alzheimer's disease or something else, this puts you at risk. So any of you working in aging services, obviously many of you work with older adults, so that's why you're here today. Any of these factors, risk factors, would place your client or patient at risk for traumatic brain injury due to a fall. So traumatic brain injuries in older adults manifest fundamentally differently than younger age cohorts. And, the differences are kind of multifactorial, but essentially got to do with the physiology of like aging. The differences are due to neurological changes, musculoskeletal, cognitive, mood, higher rates of multimorbidity, which essentially means that they have multiple chronic diseases, could be arthritis, COPD, cancer, and polypharmacy. I can't tell you what a big culprit polypharmacy is. That is multiple medications. So this is why it is fundamentally different compared to younger age cohorts. And so why have I highlighted that? Cognitive and neuropsychiatric symptoms after a TBI for an older adult may persist for the rest of their life. And why is that? Because, the brain has finite capacity to recover and adapt to both TBI and the aging process. We talk about neural plasticity. All of that gets compromised as we age. And it's difficult for an older adult with that aging process and TBI to have those kind of robust adaptive functions. TBIs that would otherwise be classified as mild, and we look at that definition a bit later. For older adults, that is a risk factor for intracranial bleeding due to all of those changes I told you, due to aging, the physiology of aging, and increased use of anticoagulation, coagulant medication, that is blood thinners. That puts them at increased risk. Remember, we talked about medication and polypharmacy. Now, a 30-year-old is highly unlikely to be taking an anticoagulant. But guess what? Older adults do. And then older adults are also more likely to have pre-existing medical conditions. We talked about multimorbidity. They could have 3, 4, 5 chronic illnesses that are associated with worse post-traumatic brain injury outcomes. Remember, we talked about depression. It could be cardiovascular disease. All of this kind of predicts worse functional, cognitive, and psychosocial outcomes for older adults. Therefore, this webinar today about how important it is to address this issue. And again, very quickly about falls and traumatic brain injury. Older adults often have gait and balance disorders, whether it is a discrete illness or I told you about ADL impairment. We've talked about medications that affect cognition and physical function are associated with high risk for falling, which is, like I said, the leading cause of traumatic brain injury. Alcohol consumption contributes to fall risk, as well as can lead to gait and balance impairment and cognitive changes when you're under the influence. And did you know that binge drinking is the fastest growing trend in Oregon, at least for older adults? That is drinking more than the recommended amount, 3 to 4 drinks on any one given time. And then we've already talked about the physiology of aging with advancing age, which also places you at risk. Basically, one thing is inefficient or reduced liver and kidney functions, which can affect medications and substance use, which then puts you at fall risk. So does age matter with a brain injury? Yes, it does. And these are all the reasons we just covered. Higher risk for brain bleeds because of the physiology of aging. Remember, we talked about intracranial bleeds and anticoagulant medications, slower recovery rates, high level of care needs, and many of them require hospitalization and then transition to skilled nursing facility. Greater likelihood of their medical chronic illnesses and mental health issues worsening, and high risk for cognitive impairment, dementia, and other neurological disorders, and we'll be looking at that. So what is traumatic brain injury? TBI is caused by a bump, blow, or jolt to the head, or a penetrating head injury that disrupts the function of the brain. And what is a penetrating head injury? Kind of like a gunshot to the head. And in both of these, it's an external force to the head. So just remember, bump, blow, jolt, penetrating head injury. That is an external force to the head. That's what a traumatic brain injury is. And here is the severity. Remember, I was talking about mild and moderate. This is mild TBI. LOC stands for loss of consciousness. So for mild traumatic brain injury, you have no loss or less than 30 minutes loss of consciousness. In moderate traumatic brain injury, you have 30 minutes to 24 hours loss of consciousness. And then in severe brain injury, traumatic brain injury. It could be, it's more than 24 hours, it's a coma. I have known patients that I've consulted on who've been in comas for 3 months or 1 month. And so that's how we rate the severity of a traumatic brain injury. And then also just want to distinguish between primary injury, that is, occurs at the time of the incident, when that bolt bump penetrating injury happens. And the secondary is what happens after the initial injury, when there is like brain swelling, lack of oxygen to the brain. So there is primary injury and secondary injury. So many of us are familiar with the primary injury. So the secondary injury is brain swelling, hematomas, increased intracranial pressure because of the fluid building up in your brain, shock, and anoxia, that lack of oxygen. These are all secondary to the initial injury, and it can have devastating impacts on older adults. Why? Because of what we talked about earlier with that physiology of aging, with polypharmacy, with multimorbidity. It puts them frailty, it puts them at risk, much higher risk for all of this. And so what increases the likelihood that your client's TBI will have a lasting effect? One is obviously the severity of TBI. We talked about what are the different kinds. Then cumulative effect, that if you have repeated injuries or falls or blows to your head. Developmental interaction, when did they occur? Childhood or your older adults? In our case, older adults. And then recent injuries. And what were the combined effects? Remember I said primary and secondary. Those are the things that will predict what will or may be lasting effects. Now, again, I'm not going to go over everything on falls, but I'd suffice it to say that it is the leading cause of traumatic brain injury. I've given you some Oregon data, but across the country. While falling is common among all age groups, correct? The severity of injury for older adults results in a loss of mobility, independence, and more frequently death. That's the message today. So keep that in mind. It is the leading cause of traumatic brain injury for older adults. And we talked about those blood thinner medications, the anticoagulant, that one study found that 9% of older adult patients with TBI were taking like a anticoagulant. You may have heard of the medication warfarin, pre-injury, and that those people were associated with more severe TBI and higher rates of death. So what's the take-home message? Older patients on anticoagulation should be given special attention with a low threshold for injury suspicion. So screen. This is a slide which I took from our Center for Brain Injury Research and Treatment at the University of Oregon, which kind of gives you a very nice graphic about the entire spectrum of brain injury signs and symptoms, and overlap between cognitive, physical, emotional, behavioral. Like, what are the changes in the brain which result in all of this happening? As you can see in the emotional side, that's what we are going to be focusing on. But since our talk is only on the behavioral health, it cannot be divorced from all of the cognitive changes that are happening, the physical changes that are happening, and behavioral changes that are happening. So they're all interconnected and overlap, though my presentation is really on the behavioral health or the emotional side of this circle. And I found this slide late last night, and I thought it was so good that here are the consequences of mild brain injury on older adults. And this is the lived experience. You have sleep disturbance. Why? Because it damages your sleep regulation centers in the brain. It causes neural inflammation. Look at headaches. That can cause mental fatigue, depression. It alter your pain centers, gait and mobility problems, because you have damage maybe to your, vestibular and your vision and to your vision centers. So you have gait and mobility problems. You have mental fatigue, which we are going to talk about, which is like trauma informed. This is all older adults. You have disruptions in your vestibular system, which is, related to your movements, so it causes dizziness, nausea, balance problems. And then you have disturbances in your ocular system, that is vision. This is on top of all that's happening with the physiology of aging. You already may have one or two eye diseases of aging, and now you have this new thing. You already may be feeling fatigued from frailty, and now you have this new kind of mental fatigue because of damage to your brain. So this is the lived experience of an older adult. This is mild. Now imagine if it was, anything else. So this was very quickly, this was a study done by AARP on all 3,600 adults 50 plus. The survey showed that 3 in 10 adults 50 plus experience a traumatic brain injury. 3 in 10, 30%. And adults who experience one or more TBI fare worse on mental health outcomes than adults who've never had a TBI. And here is what that study found. Look at depression, the red line, anxiety. And so the lower the line is, that is no injury. And as it goes up, it is 2 TBIs, 3 TBIs, as you can see. Same with anxiety, and opposite for well-being. Conversely, it goes down. And this was the study from AARP. And by the way, I have my entire bibliography at the end, so you're welcome to look these up. And that study included, where were some of the greatest impacts, mental and emotional, such as post-traumatic stress, anxiety, depression. And here was the coping mechanisms that these 50 plus, this 3,600 people said. They take their time moving more slowly. They refrain from engaging in activities that cause the injury. They brush off their symptoms simply as signs of aging. So they never report to the doctor that they fell and hit their head. They start doing some exercise to kind of stimulate their brain. And good news is they make home modifications. There was also physical impacts, and we've already talked about them. I'm not going to go over all of them, but there was definitely physical impacts, such as for sleep, headaches, and these were the things they tried: stress management, yoga, meditation, physical therapy, and then there were also social impacts, and like withdrawing from activities, fear, anxiety. And sadly, most did not seem to have any coping strategies for that. This was all in the AARP study. So with that backdrop, does anyone recognize the name Phineas Gage? Well, he's neuroscience's most famous patient, and he had a TBI. This was in the late 18th century. He was a young man, 25 years old, a foreman laying down a railway line. I think it was in Pennsylvania. And he was in the front of his team putting in, dynamite to blow up to set the rail. And the dynamite blew up prematurely. And there was a metal rod which went through the front of his head and came out from the back. He survived that injury. But guess what? He was a totally changed man after that. Nobody could recognize him because his personality changed dramatically. His entire injury was on his frontal lobe. So much so that he could never hold a job again. He was towards the end of his life, he was using substances like alcohol, and he died at a very young age of 37 when he had to move in to live with his mother and sister in San Francisco. So happened at age 27, 25, died at 37, a changed man. His personality and his mental health totally changed from this injury. And by the way, his brother donated his brain to Harvard Medical School, and it is in their museum there. So think about Phineas Gage when we look at what's the impact on mental health of traumatic brain injuries, in particular through the lens of older adults. Here are, some of the key psychiatric comorbidities. Highly prevalent is depression. It's wide ranging, 10 to 42%. That's, as high as, 4 in 10. And here are some key studies which I have put in here for you all to look at. So this was a national analysis they did of major depression through Medicare beneficiaries, 65 and over. 39% had a TBI hospital stay of more than 5 days. 37 were discharged to a nursing facility. And of that group that they were studying, before TBI, 62% of this sample had a depression. After TBI, the increase was twofold. All the people who were older and had a TBI, the prevalence of depression was twofold. Look at what was the strongest predictor of depression. Was discharge to a nursing facility from the hospital. Alcohol abuse and dependence was a strong predictor of depression in men. Increasing length of hospital stay was a risk factor for depression. And ischemic heart disease was predictive of depression post a traumatic brain injury. Now, suicide. Did you know suicide surpassed unintentional motor vehicle crashes as the leading cause of TBI-related death across the lifespan? And underlying cause is firearm injury. And as we know, suicide rate for all age groups is found in adults age 65 and older. And it is the third leading cause of injury in adults age 65 and older. And as you know, older adults overwhelmingly use firearms to die by suicide or attempt that suicide. And so that places older adults who survive at risk for a penetrating traumatic brain injury. So all of us on this call today, reducing access to lethal means screening for suicide risk among older adults is an important approach to create protective environments for older adults to decrease traumatic brain injury. Remember, I said one is false. Now, suicide using firearms is also can lead to traumatic brain injury in older adults. And guess what? The risk for suicide, and that was one of our questions polled, for people who have experienced a mild TBI, twice as high than people without TBI. So basically, it is associated with a higher risk of suicidal ideation and attempt. History of moderate to severe TBI, increased risk of suicide by firearm. And bottom line, the risk of attempted suicide increases with severity of TBI. So the more severe your TBI, the greater the risk. And I will let you read this article when you get my slide deck. Here they were looking at brain injury among, veterans. Veterans both in these studies. So take a look when you get my slide deck. So why is it associated with higher risk? Factors thought to be related to increased risk for suicide is one's ability to participate in work and home life. It is changed in a blink of an eye. Difficulty returning to work or hobbies, or for older adults, your lifestyle, your roles. So it creates social impacts, decreases quality of life, and leads to increased hopelessness and helplessness. And then you have all of those brain changes. You have a difficulty processing your emotions, problems with impulse control. You get stuck in your brain in terms of like a thought. We call that perseveration. There could be dramatic changes in your relationships with your family and friends. We already talked about fatigue, sleep. All of this places you at higher risk for suicide. And then there's dementia and TBI. Again, I'm not sure what my time is, but I'm not going to spend a great deal of time. But comorbid dementia and mild cognitive impairment are a risk factor for traumatic brain injury and can slow down recovery. And it also confounds the diagnosis of traumatic brain injury. Like, is this their dementia or is this something new from TBI? And then there are those more difficult symptoms, which we call neuropsychiatric symptoms. They increase with traumatic brain injury. In most, the one that is most disturbing is disinhibition, which you can have these neuropsychiatric symptoms with dementia, but add on that layer of traumatic brain injury and it worsens them. And this really increases caregiver burden, and obviously impairs the quality of life of the person. And these people with traumatic brain injury and dementia have a lowered threshold for stress. And so this is what happens. You already have cognitive impairment, which lowers your threshold for stress, and then you get a traumatic brain injury by a fall, and boom, you're agitated, you're disinhibited. You're unable to kind of regulate your environment, your inner emotions, because you already have some compromise, but then you add on the insult of TBI, and boom, you have a whole new array of neuropsychiatric symptoms. Sleep disturbance is common, very common sequelae. And it affects your quality of life if you're older, correct? And it can actually put you at risk for other sleep-related disorders, such as obstructive sleep apnea following a TBI. So how important it becomes to do a sleep assessment. So all across the literature, TBI was associated with increased risk of insomnia and sleep disturbance. And why am I bringing up sleep? Because sleep is a transdiagnostic clinical feature. It affects many kinds of mental health diagnoses. And so having good sleep is absolutely essential as a treatment intervention. And what we call it a modifiable treatment target. And screening for obstructive sleep apnea for older adults. Substance use. Remember I talked about Phineas Gage? He eventually took to using alcohol and had to return home to live with his mother before he passed away at age 37. Look at what Dr. Corrigan has to say. Substance abuse is a risk factor for having a traumatic brain injury, and traumatic brain injury is a risk factor for developing substance abuse. So there's a tight bidirectional relationship. I am going to focus on alcohol use in older adults. So it increases your risk for falls. The more alcohol you consume for older adults. Remember, I said binge drinking is the trend. And as we grow older, with the physiology of aging, our kidneys and livers are less efficient. So even if you drink small amounts of alcohol, they stay longer in your body and then put you at risk for falls and brain trauma. And we know already that it's the leading cause of traumatic brain injury and death. So very important for us all here to understand and manage that component of alcohol consumption for this age group. And then there's
Nirmala, 2 minutes.
Okay, TBI and PTSD. That can also develop with any kind of injury, but it can develop with a traumatic brain injury where you are also experiencing psychological trauma. Okay, here are some common symptoms between PTSD, TBI, and what's common. You can look in the middle. It is sleep, negative thoughts, irritability, memory, trouble concentrating. That's the overlap. So being skilled or knowing some resource where to send someone to tease out what is very important. And then there's anxiety. The main form of anxiety prevalent in older adults is, guess what? Fear of falling. And fear of falling is very common after a fall because it affects your confidence to navigate your environment. And you have this kind of constant fear that you're going to fall and stumble again. So you've lost that confidence. And so what do? You restrict your activities. You just sit in a chair and you lose muscle mass, and that places you at increased risk. This is what fear of falling is: reduction in balanced self-efficacy, fearful anticipation of falling, avoidance of activities that resulted in the fall. That's essentially what fear of falling is. It is an anxiety disorder and very high prevalence, 44%. And here is the cycle. You fall, you fear falling, you reduce your activity, you become very lean, you lose your fitness, and you fall again. And numerous consequences of fear of falling. So again, leading cause of traumatic brain injury is falls. And this is a lovely takeaway which I got from the National Council. Older adults who experience traumatic brain injury are at high risk for complications due to age. One impact of TBI in older adults is the development of mental health disorders, which we just spoke about. Since falls are a top cause of traumatic brain injury, taking proactive steps to prevent falls can reduce TBI risk. So what can you do? I want you to reflect on it. Do you screen for falls risk wherever you work? Do you screen for TBI if you're not in a TBI-oriented setting? And lastly, advocate for a better care model for older adults following a TBI. Because currently, they are often undertreated for a TBI. So advocate, advocate, advocate. I have a whole bunch of resources here for you. So please take a look, including MI, motivational interviewing for falls prevention. And I want to thank you all so much. Thank you, Maria, for inviting me. And falling is not a normal part of aging. Thank you.
Thank you, Norma. Great, great information. And we've got more information for you, so stay tuned. We have until 15 past the hour, so there is more information to share with you for sure. And I want to give Amanda time, so I'm just going to breeze through what I want to share with you, which is a resource that's going to reinforce what Nirmala has talked about. And I hope that you can see this guide in front of you. I hope that you can. Yes?
Yes, we can see it,
Great.
Maria.
Great. This is a tool that we created to touch on some of the things that have been shared already, which is an aging guide for anyone, whether you're in an aging setting or a mental health setting or a brain injury setting that talks about these things. How to better partner with your aging network or your brain injury network or your mental health network. Training approaches to use, screening approaches to use, some of the differences between brain injury and dementia, which we get tripped up about sometimes, I think. Aging after brain injury, and then the last two pieces, some modification of clinical interventions and some solid advice on medication management from someone who spends a lot of time in that space. When you get the slides or you access the slides in the chat, you can access this document or you can go to our website to get it. So take a look. I just want to run through this quickly. What's inside? There's a lot of information about prevalence and systemic issues here that support what has been discussed. And as Nirmala talked about, there is a lot of information there about slower recovery, but some good news too. A lot here about partners and strategies, and I'm not going to spend time here because Amanda is going to talk about this. Who your partners are, what the aging network looks like, and how to contact them. How to do training within this setting, what that can look like, and how much training maybe to delve into. A little bit about screening and assessment and how to tackle that related to what you're trying to do. And I just want to emphasize why it is important, why knowing about brain injury in this setting matters. Brain injury is hidden here. It is a vulnerable population, as Nirmala mentioned, and it is important to know that brain injury is sitting in that space. If you suspect a history of brain injury, it's important to know about it right at the start so you can make the right referrals, so you can make some simple accommodations so that things work better to support that brain injury, and you can provide some psychoeducational supports or do better clinical intervention, and the person can self-advocate. Lastly, I mentioned that there's some clinical intervention information in here, and it looks a little bit like this, and some tips on psychopharmacologic intervention. The person that wrote this section also did this guide and this section here. So I've included a link to this overall behavioral health guide as well. So enough of that, and I'm going to turn it over to Amanda. Thank you.
Thank you so much, Maria and Nirmala. Thank you for all that incredibly valuable information. I'm watching the chat, just people saying, wow, like that was so helpful and so useful. So I appreciate Nirmala being able to kind of set the stage and kind of teach us what it is that we need to know about traumatic brain injury. And my job now is to talk about how do we kind of manage that knowledge and information, and how do we build some partners to help solve this problem and continue to support older adults. So as you probably recall, my name is Amanda. I am from the National Council on Aging. So I'm going to tell you very, very briefly, because I know we're getting tight on time. I'm not going to spend a ton of time on a little bit about NCOA. If you have specific questions about our organization, please don't hesitate to reach out. My contact information will be at the end of the slides. But I want to just kind of share a little bit to get us all sort of on the same page of what we are and what we do. So let me make sure that my slides are going to advance for me the right way. There we go. So I'm going to describe our mission and work, give you some examples of some evidence-based programs. We're going to talk about community partnerships and some strategies on how to connect with those partners. So at NCOA, we vision a just and caring society in which each of us, hello, that went too fast, as we age, lives with dignity, purpose, and security. Our mission is to improve the lives of millions of older adults, especially those who are struggling. And we have a goal to impact the health and economic security of 40 million older adults by 2030. I'm happy to report that we are well on our way to that goal. And as we are now just a few years shy of 2030, we're starting to think about what's next. What are we going to do next to continue to support all of us as we age? Because the reality is, every day we're all doing it. And all of us are going to eventually cross that threshold of older adulthood. And so we should be prepared as a society to support everyone in that aging process. We serve multiple groups of people. So we have some sorry, my slides are just doing their own thing. We have some consumer-facing information for older adults themselves, and that could be parents, grandparents, neighbors, friends, really anyone who is sort of in that 55 and older category. We have our professional facing information. So those are individuals who are maybe serving older adults in senior centers, community-based organizations, social or human service agencies. Our caregivers, so those who are maybe part of multi-generational family or friends that are caring for an older loved one, and a lot of advocacy. So we are really hoping to continue to shape and support the policies that are affecting older adults and all of us as we age, and really trying to influence our policy makers. You may have seen earlier this week, if you follow us on LinkedIn, that the Older Americans Act turned 60 earlier this week. So it became an older adult itself. And we've been really doing a lot of work around making sure that our policymakers know just how important that legislation is, and how much of an impact that it has on those that we're serving and that are aging every day. So we have kind of two focus areas. We have our health side of things. Again, apologies for that slide going a little quickly there. That includes our falls prevention, our chronic disease, and behavioral health programs, and we'll talk a little bit more about those. And then on the other side, economic well-being, we have our benefits, enrollment, job training, and money management. So let me dive a little bit deeper, kind of what does this work look like? So we have our resources, we work with funding and best practices, we have tools that we put out, and advocacy. And as we go through, I'm going to tell you a little bit more about some of these different pieces. NCOA Connect, if you're not familiar with this, this is kind of our learning management system, our hub for all of our different types of live events. So Maria mentioned the Older Adult Mental Health Awareness Day Symposium. If that's not something that you've attended with us in the past, I hope that you will join us in 2026. We typically host that at the beginning of May. Next year, it might be the very, very end of April based on the way that the Thursdays fall. But that is an opportunity for a virtual gathering where we can bring people together to really focus on older adult mental and behavioral health issues, and really think about how do we continue to impact those things in a positive way. So you can jump into our NCOA Connect and see resources that are specific to professionals, specific to older adults, those caregivers and advocates as well. All right, so let's talk a little bit about some evidence-based falls prevention programs. So these, I pulled kind of the top 3 that are currently being implemented. So the National Council on Aging serves as the resource center for the Administration of Community Living's Falls Prevention Program grantees, as well as the Chronic Disease Self-Management grantees. And so these 3 falls prevention programs are 3 that are pretty often implemented within those grantees. So as you'll see, that there's a lot of connection between what Nirmala was talking about with this fear of falling, and how that can have sort of the cyclical effect on older adults, and how do we break that? How do we kind of move them out of that fear of falling and bring in that activity level a little bit higher? So A Matter of Balance is one of the programs that's very often implemented. And this is an 8-week structured group intervention that focuses on practical strategies that are going to reduce that fear of falling and increase activity level. So there's a facilitator who brings everyone kind of through this 8-week structure, and it's really kind of a fun way of getting some of that physical activity, as well as building that confidence and reducing that fear of falling. Bingo Size I would say is probably the one that I've heard the most from my team about. We have multiple organizations in the community who are implementing bingo size, and this is probably the most fun falls prevention program, at least that I've kind of heard of. It's a 10-week program that combines a bingo-like game with exercise and health education. So it's really a fun way to kind of make exercise and health education a little bit more fun and exciting and give people something to look forward to. Enhanced Fitness is another group activity that's focused on 4 key areas. So they focus on teaching people about low impact cardiovascular exercises, balance, strength training, and stretching. And just to kind of give you a feel for what some of these programs can do for participants, I pulled up just a couple of kind of quotes from those who have participated in these programs in the past. So one of them for the Enhanced Fitness program, this comes from a 92-year-old participant, and they say, I have been attending the classes for many years now. After my retirement, I must say that now at 92, these classes and our great teacher have been keeping me going in mind, body, and spirit, feeling enhanced. And then one of the participants from A Matter of Balance said, I'm picking up my feet more when I walk. I'm not trying to carry all my groceries at once into my house. I'm using a cane more when I walk on my lawn. I'm turning on more lights as I travel in my home. So things that can feel really simple that are really can have a game-changing effect on these older adults when we can help them engage in these types of activities. In the slides, I put a link to the page where we have all of the falls prevention evidence-based programs, as well as the Fidelity Hub. And then one of the other really fun activities that we do each year is a falls prevention awareness week, which comes in September. And so I have the information for that as well. It's a great opportunity to really think about how do we start to bridge some of these gaps in getting people connected to these great programs so that we can reduce that fear of falling. We can start to reduce the negative impacts of falls and that including those traumatic brain injuries and some of the behavioral health components. So I wanted to also spend a little bit of time here talking about some of the behavioral health community programs, which can be a supplement to a person maybe engaged in a falls prevention program. And we sometimes see kind of both of these things happening at once. So just a really quick overview of a couple of those programs. The Healthy Ideas program is something that integrates depression awareness and management into existing case management services. So this is a person who's already connected with a case manager and really focusing on reducing the impact of that person's depression diagnosis. And as Nirmala said, we know that there can sometimes be an increase in depression diagnoses after a person has fallen. So this could be a supplement to supporting that person in their recovery. The Pearls program is, again, aimed to improve the quality of life and reduce those depressive symptoms. And the WRAP program is a self-directed process that helps the person create the life and wellness that they want. So we can see these programs kind of being used simultaneously and together to really help build the confidence of the person who maybe has experienced a fall or has that fear of falling, and we're trying to build them up so that there is less likelihood of that fall. So community partnerships are a huge part in how we help to solve this problem and how we continue to reduce the impact of these issues. So I wanted to spend a little bit of time talking about how do we think about building partnerships. And then we'll talk about what are some maybe creative places that you could build those partnerships that maybe you haven't necessarily thought of. So I pulled together some information and resources kind of around what does partnership building look like, what makes that successful, and came up with sort of 6 key takeaways that I wanted to share with you all. So the first is when we're thinking about building a partnership, we want to spend time getting to know the organization. So we're going to have to do a little bit of digging, do a little bit of research, and find out what are their goals, what's their mission, where are those commonalities that we have between the work that we're trying to do and the work that they're doing. So once we know a little bit more, that's going to give us an opportunity to find that alignment between our mission and the potential partner's mission. The more alignment that we can find, the more commonalities we can find, hopefully the easier it will be to build that partnership because we can show what's the mutual benefit for each of us. We also want to be aware of what are their pain points or the problems that they're trying to solve. And is there a way that we as an organization can help solve that problem? So what are the ways that we can support their work? We might do that by highlighting our expertise and the resources that we bring to the table. So what are the things that our organization is able to support them in? Maybe they're having a difficult time reaching individuals who have experienced a traumatic brain injury, and that's a group that they really want to kind of focus a little bit more on. And so if your organization being that hub for those who are living with a traumatic brain injury, that could be the resource that you're able to bring to the table to get them connected and to support that work and that future goal that they have. We also want to take some time to explain how our programming can help identify or help address that identified problem. So the issues that they're hearing or that we've found that they tell us, how are we going to be able to support that with the programming that we have in place? And finally, it's really important to think about what are the expectations of the partnership. Is this something where you're kind of transferring knowledge to each other? Are you building connections to other people in the community? What is the expectation of how you're going to work together? One thing I can say is that it's really difficult to build a good partnership if it feels one-sided. So making sure that we know what that alignment is, that we have those commonalities, that we're able to come up with a mutual goal is what's going to help us set those expectations. So let's think about kind of some potential community partners. So Maria showed really quickly the slide that kind of like federal level, state level, local level, and then we get down to the community level. So what are these people? What are the community partners that maybe you're working with, or maybe you leave today saying, "Ooh, I had never even thought about that particular community partner. I'm going to go ahead and reach out." So I pulled a list of just a couple ones that we've seen work with some of our grantees and that I have sort of worked with in previous positions as well. So I'm going to just really quickly kind of pull them all up and we'll talk through them. And look at this, I see somebody right in the chat, Centers for Independent Living. Absolutely, there it is. Yes, home health departments. Absolutely. Senior centers. If you're not connected with your local senior centers, they are a fabulous hub of resources and connections. Sometimes they might even be the only hub in your community. Parks departments, absolutely a really great opportunity. They often are the ones who have those rec centers. Locally, where I am in Northern Maryland, our rec centers are part of the Parks department, and that also happens to be where our senior centers are located. So it all kind of comes together. Libraries are another really great community partner. And why is that? Well, libraries are a community hub. When I think about a library, I think, it's not just about the books. That's a great aspect of the library. That's a kind of the thing that we most often think about. But if you have a really robust library system that's often implementing different programs and has a lot of activities going on, find ways to connect with them and see if you can bring some of that work into their space as well. Health departments and area agencies on aging, another great potential community partner. Pharmacies, we have a grantee right now that is working with a pharmacy that is on their prescription pad information has details about some of their evidence-based programs. So every time somebody's in there, they're able to kind of get that information right then and there. For those of you who are familiar with certified community behavioral health clinics or CCBHCs, and the federally qualified health centers, those are other really great potential community partners. And I see in the chat a couple that I did not include on the list. Obviously, I would say that this is not an all-inclusive list, but universities, including your local community colleges. Sometimes even partnering with your K through 12 schools if there's joint programming or ways that you can support each other in that sense. Local brain injury associations, yes. Caregiver support groups, absolutely. Hospice organizations, doctors' offices, the list really is endless. So my takeaway here with this one is think outside the box. We sort of know our traditional partners, the people that we typically kind of go to when we think about building those partnerships, but get creative and find some ways to kind of think outside the box as you're building those partnerships. Okay, I know that we went through really, really quickly. There are a couple resources, links here that you'll have access to on the presentation. Our partnership assessment tool is a great one as you're thinking through approaching a new partner. There's some tips and tools for successful partnership building. That's a video. We have a webinar on here and some resources on strategic partnership. So that was very, very quick. Thank you for indulging me in that very quick conversation. I have my contact information here, so if you have any questions, I'm happy to answer those. Feel free to reach out. And Maria, I also wanted to acknowledge, the YMCA and food banks and farmers markets, all excellent other ideas. So hopefully your brains are spinning a little bit and you have some new thoughts on kind of how you can partner with other organizations to continue to support the older adults that you're working with.
Outstanding. Outstanding. Thank you, Amanda. And I'm intrigued about the partnership assessment tool. I'm going to look that up the minute we finish because I have not seen that. Very appreciative of all of that. And I know we're very close to time, and I see we've got some hands raised, and I see some questions in the Q&A. Thank you so much. Nirmala, I'm going to throw one of these at you just to answer really quickly. I see from Brittany, when working with individuals experiencing behavioral health symptoms who also have a brain injury, should the approach be different in how we support them with skill building?
Thank you. Yes. And in fact, Maria, we were talking about, how do you adapt behavioral health interventions for people with traumatic brain injury. Absolutely, your approach would be different. So one thing you would need to know, have a better understanding of what exactly is the outcome of their brain injury. Do they have memory problems? Do they have problems with processing speed? So there is no magic. You just adapt your evidence-based therapies with this overlay of knowledge about brain function. And so, simple things like giving things in writing, talking slower, asking, checking back, did you get what I said? Do you want me to repeat it? So simple adaptations, but powerful in their outcomes.
Great, great. I see there's another one on here about thoughts on why the medical community is far more likely to diagnose a mental health diagnosis without inquiring about brain injury. Do either of you want to comment on that?
I was actually just starting to type a tiny little message knowing we were close to time, but I think two of the really important parts of that are the isms that still exist. So ageism, I think a lot of people assume that mental health conditions are a normal part of aging. They are not a normal part of aging. And so I think that ageism kind of plays in where the medical field just sort of assumes, oh, they're old, they're depressed, here we go, check that box and move on. And I think there's also a lot of stigma, not just from the medical side, but I think older adults feeling the stigma of their changes in independence, maybe their changes in their abilities. And so those two isms, I think, really play a role in why most people say, oh, must be a mental health concern, and they don't dive deeper.
And I will add to that, Amanda, very often it's also a lack of knowledge. The workforce, the broad spectrum of people who work in this field don't have adequate knowledge about what is TBI. So they don't know how to ask that question or how to screen for it. And when you're an older adult presenting with multiple other issues, it's very easy, to not to do that. And so standardizing that screening that I wrote in my presentation is key, and building the workforce like we are today.
Yeah, absolutely. Thank you so much for sticking in there with us. We appreciate all of the great information, and thank you so much for sharing your time with us. You will get an evaluation in an email later today, and we love to see your feedback. Have a great rest of your day, and thank you.
Thank you.
Thank you, Maria. Bye.
Thank
Bye,
you.
Amanda.
Bye, thank you.